Hello, we're Team PULMAtech, and we're working with Everest Life Sciences on the Alternative Access TAVR Improvement Project. I am Francis, the project lead. My fellow PULMAtech members are Lance, our design lead, Gabriella, our data manager, Robert, our coordinator, and Joshua, our quality control manager. Our mentors are our directors of R&D from Everest Life Sciences, Alon Tamir and Jeffrey Kosako. Problems and needs. Transcatheter aortic valve replacement, or TAVR, is a minimally invasive procedure to replace diseased aortic valves with a prosthetic biocatheter. The Edwards introducer sheath is a vital component of TAVR that provides a protective access channel for catheter tools to enter safely into the artery using a specialized tip to prevent damage. The sheath must be inserted completely and is designed specifically for the femoral artery, known as transfemoral access. However, this may be fatal for patients with highly tortuous or calcified femoral arteries. In such cases, the clinician will use alternative access points such as transcarotid or transsubclavian. These routes are significantly shorter than the length of the introducer sheath, forcing an extra clinician to steady the sheath so as to not overpenetrate the heart. This is highly inefficient and unstable, increasing the risk of vascular trauma. This poses a significant clinical need to properly adapt the introducer sheath for alternative access market strategy. Our device would be used by cath lab technicians in TAVR hospitals. The market size for TAVR is projected to be about $12 billion by 2028. Our primary competitors are Medtronic, Livanova, and CryoLife, but none have any products currently on the market addressing alternative access. Our business model involves creating a low-cost device sold within the original Edwards packaging. Design principles. Our device, the DuoLink, allows clinicians to adjust the sheath length to match the patient's vasculature at various access points while maintaining the original tip geometry. To implement our device, a clinician first cuts the sheath flush with the hub. The device is then snap-fitted onto the hub. The clinician then slides the sheath onto the DuoLink expandable tip. Finally, the compression nut is tightened to secure the sheath. Evaluation criteria. For our design criteria, we focus on the ease and complexity of assembly, ability to decide sheath length, and maintaining sheath integrity and sterility. Our acceptance criteria consist of a maximum 5-minute assembly time, a 10 Newton maximum assembly force, a 3 mm tolerance for length, the ability to survive at least one full rotation with 25 pounds of shear stress, and withstanding a minimum of 258 mm mercury of pressure. Validation and verification. We first performed a hemostatic pressure test to detect leaks under increasing pressures. Our device failed and leaked at 129 mm mercury, half the minimum pressure considered safe in the bloodstream. We plan to fix this in future iterations. The next test evaluated the flexural durability of the sheath connection. A weight of 25 pounds was attached to the DuoLink and rotated by a robotic arm. Our DuoLink underwent 14 rotations before failure, when it only required 1 rotation to be considered safe. Finally, we had a clinical specialist practice using our device on a silicone femoral model. She then gave us feedback on our methods. Thank you for your time and consideration.